Welcome to Essential Neuroanatomy Review, Lesion Localization in Neurology, CEREBRUM. This is David Lee Gordon, Professor of Neurology. For Essential Neuroanatomy Review, the learning objective is to localize a lesion in the nervous system based on clinical presentation, that is to say, the history and examination. The cerebral cortex consists of 5 zones: the frontal lobe, the parietal lobe, the temporal lobe, the occipital lobe, and the insula. As you can see on the sagittal view, the frontal lobe is in fact in the front. That is the only part of the brain that has a motor function. The parietal, temporal, and occipital lobes more posteriorly all have sensory responsibilities. And the frontal lobe is the headquarters for motor control, for reasoning in the more anterior frontal lobe, the prefrontal area we call it. And on the left side of the brain in most people, the motor speech area. The parietal lobe, right behind the central sulcus, separated from the frontal lobe by the central sulcus, is the headquarters for sensation, tactile sensation, as well as the inferior visual field pathways, the sensory speech on the left side of the brain, and attention on the right side of the brain. The temporal lobe, which is inferior to the parietal lobe and is separated from the frontal and parietal lobes by the Sylvian fissure, it looks like the thumb of a boxing glove, if you will, is where auditory sensation is headquartered, as well as memory and emotions, the superior visual field pathways, and another area for sensory speech on the left side of the brain. The most posterior lobe, the occipital lobe, is the vision headquarters. The insula, which means island in Latin, is not seen on the sagittal view. It is only seen on the coronal view. It is the cortex that is just inside that Sylvian fissure that is obscured on the sagittal view by the frontal and parietal lid called the operculum and the temporal lid or operculum. You separate those out and you could see the insula hiding behind it, and you see it more easily on the coronal view. The insula is not often discussed, but it's really important. It is the headquarters for the autonomic nervous system. It works closely with the hypothalamus to control the autonomic nervous system, and also works closely with the medial temporal lobe in the function of emotions. Now let's look at the 4 main functions of the cerebral cortex, represented by the acronym VAN, G, or VANG. And we'll start with visual fields. First of all, if you look at the picture at the top of the slide, the X stands for the chiasm. The word chiasm comes from the Greek letter chi, C-H-I, which is an X. That's the crossings of part of the visual pathways. I'll describe in a second. On each side of the brain, there are parietal radiations that run superiorly and temporal radiations that run inferiorly, and they go back to the occipital lobe where the headquarters for vision is. So looking at the axial view of the visual pathways here, looking at it from the top of one's head, for example, the images that are on the outside, the temporal fields, project to the inner or nasal aspect of the retinas, and these nasal fibers cross at the chiasm. That's the chiasm. The X where these purple nasal fibers that are seeing the temporal fields are crossing. Notice that the nasal or medial inner fields project to the outer or temporal part of the retinas. And these fibers that are temporally located but see the nasal fields, run ipsilaterally. They do not cross at the chiasm. After the chiasm, you'll notice, behind the chiasm, you'll notice that the parietal radiation is seeing everything on the opposite inferior quadrant. And the temporal radiation is seeing everything in the opposite superior quadrant. In order for one to have a hemianopsia, a homonymous hemianopsia, and the word homonymous means that the deficits are the same in both eyes. The left half of vision in each eye would be a homonymous deficit. You must have, in order to get a homonymous hemianopsia, a lesion in the right brain behind the chiasm, number one. That's number one. And there are only two options, in essence. A combination of parietal and temporal radiation lesions on the right, or an occipital lesion involving both upper and lower occiput. Those are the only two ways to get that kind of a visual field deficit. Now, how do you tell the difference when you see a patient, whether the lesion is in the occiput or parietal temporal radiations? And the answer is what other things the patient has, what other symptoms or signs the patient has. If the lesion is in the occiput, you can see there's nothing else in the occiput except vision. So an isolated hemianopsia is going to be located in the occiput. A person, on the other hand, with a hemianopsia due to parieto-temporal problems is going to have other problems. Going to have a hemiaparesis, going to have a hemisensory, going to have neglect, going to have maybe aphasia if it's on the left, etc., etc. There'll be something else going on because the parietal and temporal radiations are not actually next to each other. The parietal is superior to the temporal, and they're not next to each other. In order to get a quadrantenopsia, you have to either pick off one of the radiations. So a superior quadrantenopsia would be have a lesion in the temporal radiation. Remember that the parietal sees the inferior, temporal sees the superior. Everything's upside down and backwards in terms of fields when it comes to where the control of the vision is in the brain. So the right temporal radiation lesion would gives you a contralateral superior quadrantenopsia. Homonymous, by the way, because same in both eyes. You could also, however, get the same exact deficit by having a lesion in the inferior aspect of the occipital lobe. And then, to finish the discussion, an inferior quadrantenopsia is going to be caused by a lesion in either the contralateral superior or parietal radiation or the contralateral superior aspect of the occipital lobe. In summary, cortical lesions behind the chiasm produce homonymous deficits. And said in the opposite way, any homonymous deficit must be due to a cortical lesion behind the chiasm. Let's now proceed to the next function of the cerebral cortex in the acronym VAN-G, aphasia. And there are three main aphasia functions: expression, reception, and repetition. We're going to talk about all three. Let's start with expression. An expressive aphasia is a condition in which the patient has poor expression, difficulty getting out words. It is always due to a lesion in the frontal lobe in the dominant hemisphere. By definition, the dominant hemisphere is the side with language. And it's the left side in 99% of right-handed people and 75% of left-handed people. The frontal lobe in the dominant hemisphere creates spontaneous language, and expresses it via the Broca area in the posterior aspect of the inferior frontal gyrus. Note that the Broca area is near the face and hand motor cortex in the frontal lobe. So the Broca area, which helps you express language, needs the face musculature to speak and the hand musculature to write when expressing. So it's near those areas. I want to point out, however, that the Broca area is not the only area that helps create spontaneous language. The entire frontal lobe is involved in thinking about words you want to say and then expressing them. They just happen to be processed through the Broca area. So a lesion anywhere in the green area here, basically, in the frontal lobe, can cause some element of expression problem. Expressive aphages are also known as anterior aphages because they are in the anterior part of the brain, or motor aphages because they are in a motor area, the frontal lobe. And since they're in the frontal lobe, they're often associated with right-sided motor deficits. Let's now discuss the next language function, reception. Receptive aphasia refers to a condition in which a patient has poor reception or difficulty understanding words. It is due to lesions in the more posterior part of the brain, the parietal or temporal lobes. The Wernicke area in the posterior aspect of the superior temporal gyrus in the dominant hemisphere, again, which is usually the left side, receives language and distributes the information to both the temporal and parietal lobes for comprehension. So note the Wernicke area is near the auditory cortex in the temporal lobe, so you have to hear things to comprehend them, and it is also connected to the visual cortex in the occipital lobe. You can read things, for example, to comprehend them. But in order to understand, it takes more than just the Wernicke. It takes other areas of the temporal lobe and parietal lobe to process that information. So lesions anywhere in the parietal and temporal lobe can cause receptive aphasias. Receptive aphasias are also known as posterior aphasias because they, in fact, occur due to lesions in the posterior part of the brain, and sensory aphasias because they're related to the posterior part of the brain where sensory control occurs. And as a result, they're often associated with sensory deficits such as a visual field deficit or a tactile sensory deficit. The next main language function to discuss is repetition. To repeat, language enters the Wernicke area in that superior temporal gyrus and travels along a band of white matter called the arcuate fasciculus in the perisylvian area. It wraps around the sylvian fissure there and exits via the Broca area in the frontal lobe. I call this the repetition loop. So you hear or read something, it goes into the Wernicke, and then to repeat that, whatever you heard or read, it goes right to Broca area, to the Broca area, and you can speak it or write it. Now, I want you to notice that this is, in order to repeat, you don't have to actually think about language, and you don't have to process or comprehend language. There's no need, people do not necessarily understand what they're repeating. That's the way the brain is wired. So repetition is an automatic phenomenon, and it's amazing sometimes for people who are novices in seeing patients with language deficits or aphasias to see a patient who can't hardly talk or speaks only gibberish but can repeat perfectly. That's because this is a separate function. Expression, reception, and repetition are three separate functions in the brain. So that repetition loop, once again, is Wernicke to arcuate fasciculus to Broca. The third main function of the cerebral cortex that we will discuss today is neglect, again in the acronym VANG or VANG, N for neglect. Neglect refers to lack of attention to and lack of awareness of one side of the body, typically contralateral to a brain lesion that is not attributable to weakness, sensory loss, or visual field loss. And it's also called hemispatial neglect or hemi-inattention. It is nearly always due to a focal lesion in the parietal lobe of the non-dominant hemisphere, which is almost always the right parietal lobe. And the patient has so-called denial of left hemispace and hemibody. So there are two different degrees of neglect we will discuss, a severe form and a mild form. The severe form of neglect is manifested by denial of illness completely. It's called anosognosia, denial of illness. The patient doesn't even know they've had a stroke or some other lesion problem that's led them to have the deficit. They don't recognize the deficit. And along with that often goes denial of body parts, asomatognosia. So they may not even know that the right arm, or the left arm actually, the left arm that you elevate to say, whose arm is this? They'll say it's your arm. They won't know it's their own arm. So denial of illness, don't even know they've had the illness. Denial of body parts, don't even know that's their own arm when it's weak and they don't move it. When you say to move it, they don't move it because they don't know it's theirs. Now, neglect often improves to a degree, and they can also even present mildly. And mild neglect is very different. In mild neglect, the patient has what's called extinction to double simultaneous stimulation, or DSS. And the two main ways to test this are visual and tactile. So if a person, for example, who has normal visual fields, and you show them fingers in each field, and they individually, and they see both, they count fingers correctly in each field, but then you show them fingers in both sides, both fields at the same time, right and left, and they only see the numbers on the fingers on the right, then they are extinguishing to visual double simultaneous stimulation. That's a very dangerous situation. A patient with extinction to visual DSS cannot drive a car, because if they were driving and the two things happen simultaneously on both sides of their visual fields, they wouldn't see the one on the left, and they might hit somebody or get an accident. The other testable form of extinction to double simultaneous stimulation is tactile. So the patient, in this case, must have normal touch. Where am I touching you? The right hand. Where am I touching you? The left hand. Perfect. And then you touch both at the same time, and they say the right hand. They did not feel the left, only when you touch the right and the left together. That's called extinction to tactile double simultaneous stimulation. It's a mild form of neglect. Let's now cover the last of the main functions of the cerebral cortex, covered under the acronym VAN, G, or VANG. G for gaze or gaze preference. The term gaze refers to yoked eye movements. The eyes have to move perfectly together in order for each eye to see the same exact thing. And movement of those eyes is controlled voluntarily through your frontal cortex, the frontal eye fields. Frontal eye fields is a confusing name. It doesn't have anything to do with visual fields. It has to do only with the motor control of eyeball movements. Gaze preference refers to deviation of both eyes to one side or the other, left or right, due to lack of volitional or voluntary control of gaze, with normal eye movements on Dahl's eye maneuver. In other words, the eyes can move, they just can't voluntarily move, can't move if you want to move them. And gaze preference is often accompanied by head deviation as well. Gaze preference is due to a lesion in the frontal lobe. It's a motor problem, and all motor problems start in the frontal lobe, all upper motor neuron problems. The specific area of the frontal lobe is called the frontal eye fields. The frontal eye fields is a confusing term because it has nothing to do with visual fields, which is a sensory phenomenon. It is a motor issue. Frontal eye fields is an area of the frontal cortex anterior to the motor cortex that controls eyeball muscle movement. And the right frontal eye fields make your eyes look to the left, and your left frontal eye fields make you look to the right. Let's look at this example in the slide here. A lesion in the left frontal eye field means that your eyes cannot look to the right voluntarily, so they drift to the left, and you have what's called a left gaze preference. Normally what happens is a left frontal eye field will go down to that pons, the horizontal gaze center of the pons, and say, hey, make the eyes look to the right. But it can't do that in this case because there's damage in the left frontal eye field. So the eyes drift to the left. A left frontal eye field lesion gives you a left gaze deviation, which is clarified as a gaze preference once you realize that on Dahl's eye maneuver, the eyes can look to the right. The frontal and parietal lobes have different areas controlling the face, arm, and leg. And this separation is often called a homunculus. Homunculus literally means little human being, and refers to this cerebral cortex topographic organization of body control in the frontal motor cortex and parietal sensory cortex. In general, the frontal and parietal cortices that control face are inferolateral. The areas that control the arm are superolateral, and the areas that control the leg are medial or parasagittal. Cortical lesions result in deficits isolated to face or arm or face and arm or leg because of those separations. That's not the same as for subcortex. When you get to the subcortex, all the wires from the face, arm, and leg areas run together. So an isolated face problem can be in the frontal cortex, or either if it's a motor problem, or parietal if it's sensory. And you can see from each of these depictions how you can have isolated lesions in different limbs, face and or limbs. The cerebral cortex is unique in the sense that, unlike most other cells in the body, they can function too much as well as too little. Therefore, whenever considering lesions in the cerebral cortex, one must consider, is it a destructive lesion or an irritative lesion? In a destructive lesion, there's hypoactivity, too little activity. And usually that's an anatomic or structural problem. Irritative lesions, where there's too much activity of the neurons, hyperactive dysfunction, is a physiologic phenomenon usually. And the two physiologic conditions that cause hyperactive cerebral cortex neural dysfunction, i.e. the two conditions that cause irritative lesions, are seizures and migraine. A seizure is an episode of increased electrical activity in the cerebral cortex neurons, and a migraine attack is an episode of increased chemical activity in cerebral cortex neurons. Let's discuss the main seizure types and the classification's relationship to localization. In this slide, one can see that the yellow areas are the areas of hyperactivity. When the neurons throughout the cortex are firing concurrently, we call this a generalized seizure. When the seizure focus is in one smaller area or an isolated area, we call it a focal seizure. And there are two main kinds of focal seizures: focal aware, in which a patient is awake and aware the entire time they're having the seizure, and focal impaired awareness, in which the focal cortex is the site for the beginning of the seizure, but there is somewhat of a spread across the corpus callosum to the other hemisphere, giving you this bicerebral dysfunction and an element of impaired awareness. There's also a type of seizure that starts focal and becomes generalized. We now call this focal to bilateral tonic-clonic seizures, where it starts in a focal area, and in most cases this goes to the thalami, and from the thalami spreads to both sides of the cortex diffusely and ends up with a generalized seizure: focal cortex to thalamus to diffuse cortex. So the two most common generalized seizure types are generalized absence seizures, also known as non-convulsive seizures, and generalized tonic-clonic seizures, also known as convulsive seizures. The generalized absence seizures occur almost only in childhood. They are manifested by staring and what's called automatisms. That's automatic behavior like picking or blinking or lip smacking. And that can also occur, by the way, these automatisms and staring in focal impaired awareness seizures, so they can be mistaken for each other. But here's the difference. The absence seizures have no aura, no warning whatsoever, no aura, and no postictal state. It's just a few seconds, not minutes, by the way, a few seconds of impaired awareness and automatisms. That's it. And often they occur multiple times in a day. Absence always begin in childhood, and the typical age range is ages 4 to 10. And they can continue into adulthood if you started in childhood. They never start in adulthood, and they're really very uncommon in adults in general. We will talk in the next slide about generalized tonic-clonic or convulsive seizures. There are other seizure types too: isolated tonic, isolated clonic, so-called atonic. That's the usually children with bad brains from congenitally who collapse a lot and have these lack of tone seizures. And there's also myoclonic seizures. We will not discuss those in this talk today. As the name implies, generalized tonic-clonic seizures involve the entire cerebral cortex. That is to say, they are generalized. And there are two main phases: the tonic phase and the clonic phase. During the tonic phase, there is stiffening of the muscles, increased tone. There are diffuse muscle contractions. The limbs extend, the back arches, the jaw clenches, and the diaphragm and abdominal muscles contract. This results often in tongue biting, an abnormal cry or shout, and urinary or fecal incontinence. The clonic phase, on the other hand, stands for shaking. Clonus is abnormal shaking with increased tone. Clonic phase is shaking. So after the stiffening of all the muscles in the tonic phase, the muscles then have rhythmic muscle contractions in the limbs. And the problem here is this can result in injury to head and limbs from striking hard surfaces. So it's very important when seeing these patients to protect their head and limbs by using towels or coats or pillows or any soft surface you can. Generalized tonic-clonic seizures can be primarily generalized, start generalized, with involvement of all four limbs. In this case, there'd be no aura and no focal postictal deficit because it's just all the neurons happening at once and then not working all at once. On the other hand, sometimes a focal seizure can lead to a generalized seizure, a so-called focal to bilateral tonic-clonic seizure. The reason, the clinical clues that this is occurring is if there's an aura before the generalized seizure. Anytime there's an aura before a generalized seizure, it was a focal to bilateral tonic-clonic seizure. Or if there's a very prominent focal postictal deficit. For example, if someone has what seems to be a generalized tonic-clonic seizure, but afterwards has a hemiparesis, it's pretty clear that that was a focal seizure with a bilateral tonic-clonic seizure as a result, as opposed to a primary generalized seizure. Focal seizures, formerly known as partial seizures, occur when there is a focal area of the brain that is got the increased electrical activity, and it comes in two kinds: focal aware seizures, formerly known as simple partial seizures, and focal impaired awareness, formerly known as complex partial seizures. The focal aware seizures have increased electrical activity limited to a focal part of the cortex, and there is normal consciousness. There should be focal symptom referable to wherever the seizure focus is. If the seizure focus is in the frontal lobe, for example, there may be limb shaking. In the parietal lobe, there may be tingling. In the occipital lobe, lights in the vision. In the language center, aphasia. In the memory area, such as the medial temporal lobe, deja vu. And there's often a postictal focal deficit that is consistent with what those focal symptoms were, followed by too much activity in a focal area. There's too little activity in that area, and that's the postictal state. Focal impaired awareness seizures, formerly known as complex partial seizures, occur when there is increased electrical activity in a focal part of the cortex that spreads to a part of the contralateral cortex, and this bicerebral dysfunction leads to decreased consciousness or awareness. These patients often have open eyes and they're just staring blankly, and sometimes lay folks and witnesses don't know there's a change in consciousness. They interpret it as someone just not wanting to pay attention, but they in fact don't have memory for the event and they have decreased consciousness. There often is an aura, and that's a big clue to it that your seizure is a complex partial seizure or a focal impaired awareness seizure. And these focal symptoms vary based on where the seizure focus is, just like basically the same set of symptoms I discussed with the focal aware seizures. The focal impaired awareness seizures also can have automatisms, like the absence seizures, with picking, blinking, and lip smacking. But the difference is they have auras and they have postictal states. And these postictal states also vary based on the location of the focus. They can have delirium or confusion, depressed consciousness, or focal deficits in the postictal states of focal impaired awareness seizures. The common misperception about migraine is that it is a pain syndrome when in fact it is a brain syndrome. And the migraine aura is in fact like a slow motion seizure. There is a brain chain reaction during a migraine aura, a chemical chain reaction across different areas of the cerebral cortex that leads to symptoms that travel in the body and progress from one type of symptom to another. If you look carefully here at this slide, the brain depicted here, the sagittal view of a brain, shows that posteriorly there is the occipital lobe would be the visual symptoms. And that's the most common of the auras, a visual symptom, spots, dots, zigzag lines, flashing lines, etc. And then in front of that, the parietal lobe, where you get sensory symptoms, mainly tingling, traveling tingling in the body, because the symptoms go from the face area to the arm area to the leg area or some other direction. They can go leg to arm to face, etc. Followed by sometimes weakness. There's a thing called hemiplegic migraine that occurs when the motor area is involved in a migraine aura, and you can have confusional migraines. Migraine can cause vertigo, go to the temporal lobe or insula to cause vertigo. It can go to the insula to cause dysautonomia and changes in pulse, blood pressure, respirations, and GI tract symptoms. It can go to the temporal lobe and cause confusion, amnesia. Now, the key to knowing it's a migraine aura causing these things is that these episodes come and go. They're transient. They are stereotypical. In other words, the patient has had several other ones, recurrent similar spells in these genetically determined locations in the cortex based on what migraine gene they have. And the sensory phenomena are usually, not always, but usually positive initially. But positive means lights when it comes to, or bright things. That's why we call them scintillating scotomata for the visual phenomena, or they are positive sensory phenomena, tingling or paresthesias. Often the positive phenomena are followed by negative, so they start with the flashing lights and they have holes in the vision, or it starts with tingling followed by a decreased sensation. But usually it's positive. The other fact, because it's a chain reaction across the brain, unlike anything else that affects the brain, the symptoms tend to travel or migrate from one part of the body to another, as I was mentioning before. For example, the face, the arm to leg, etc. And because it, quote, is a traveling brain reaction, chain reaction across the brain, it goes from one area of the brain, such as visual to parietal, etc. So once again, the symptoms are progressive from, for example, visual to tingling to abdominal, etc., etc. Lesions in the cerebral subcortex result in hemibody syndromes, pure hemibody syndromes. Because there are no horizontal wirings in the subcortex, all the findings are from the vertical pathway disruption. So typically patients have face-arm-leg involvement or arm-leg involvement. These unilateral subcortical lesions give you contralateral deficits, such as hemiparesis, where there's weakness, hemisensory deficit or sensory loss, or hemiataxia, discoordination. If the lesion is below where all three areas, face, arm, leg, have entered into the corticospinal, corticobulbar tracts, then you'll have face, arm, leg involvement. Note that if a lesion is higher up in the subcortex, it can go higher than where the face neurons enter into the mix, and the corticobulbar tract's not yet there. So when it's just leg and arm, sometimes the lesion means it's actually higher in the subcortex, as depicted in this picture. In the subcortex, because the wires, these neural pathways for the face, arm, leg are bundled together, it's really unusual to have isolated limb weakness or sensory deficit. Bilateral subcortical lesions can result in a unique phenomenon called pseudobulbar palsy, which in essence is disinhibition from disconnecting both frontal lobes. So and the interesting thing about it is this can occur either with bilateral concurrent lesions or an old lesion on one side and a new lesion on the other. So the classic findings in someone who has bilateral subcortical lesions, it makes sense, are spastic quadriparesis. They have increased tone, upper motor neuron problems bilaterally, and urinary continence that is due to lack of voluntary control, like a baby or like a person who's got bifrontal disease from Alzheimer's or something. It's lack of voluntary control. So it's full volume, maybe some urgency, but no hesitancy, and normal volumes, right? This is a classic, like a baby urination, urine incontinence. The thing that is unique about these folks with bilateral subcortical lesions is this pseudobulbar palsy concept, where they get bifacial weakness, dysarthria, and dysphagia. That's why it's called pseudobulbar. Pseudobulbar means fake brainstem palsy, because back in the late 1800s, early 1900s, these doctors said, oh, this problem's obviously, in the brainstem. And then they'd find it wasn't in the brainstem. In the autopsy, it was bilateral subcortex. Because when you unhook bilaterally the subcortex, both sides of the face don't work. You have swallowing problems, dysphagia, speaking problems, slurred speech, dysarthria. But the thing that's fascinating is they get this phenomenon called emotional lability, or pseudobulbar affect, where they suddenly cry for no reason or laugh for no reason. Crying is more common than laughing. And it can be very disturbing to folks. Now these lesions, again, this pseudobulbar syndrome, I should say, can occur either from concurrent lesions bilaterally, commonly due to degenerative diseases. There are these various Parkinson's plus type syndromes, or due to one old lesion, like an old stroke on one side, and then a new stroke on the other, and suddenly the patient has pseudobulbar palsy. A large part of the cerebral subcortex is deep white matter. And deep white matter is especially prone to the effects of vasogenic edema. The myelinated deep white matter is less dense than the gray matter. Thus, vasogenic edema only occurs in white matter. To describe this more specifically, with blood-brain barrier disruption, endothelial tight junctions become porous, and water leaks out of the capillaries and selectively fills and swells this spongy white matter, not the concrete gray matter. The vasogenic edema does not affect the concrete gray matter, only the spongy white matter, as depicted here on this slide. On the left, you have a normal blood-brain barrier. On the right, the water leaks through the vasogenic edema, extracellular fluid leaks through the permeable capillary when there's blood-brain barrier disruption and fills the white matter, does not affect the gray matter. Now, this leaky blood-brain barrier concept with vasogenic edema typically occurs in two main settings: specific mass lesions such as brain tumors and abscesses. Brain tumors and abscesses disrupt blood-brain barrier and cause vasogenic edema into the deep white matter. And by the way, as we've discussed in the brain imaging lecture, that is also the reason for contrast enhancement of those lesions, because contrast enhancement is when the contrast leaks out of that blood-brain barrier. Another phenomenon that causes vasogenic edema is hypertensive encephalopathy. That's a bit of a misnomer, because you don't really have to have bad hypertension to have hypertensive encephalopathy. Hypertensive encephalopathy simply is a condition in which the blood-brain barrier generally is disrupted, leading to water, vasogenic edema, leaking through into the deep white matter. Now that can occur because of a sudden rise in blood pressure. It can also occur because the blood-brain barrier itself gets disrupted by chemotherapy, for example, or for example in eclampsia, when you have urinate out proteins and have low protein, then you have a leaky blood-brain barrier, and even at a lower blood pressure, you get this so-called hypertensive encephalopathy syndrome with vasogenic edema in the deep white matter. Localizing lesions in the cerebrum also requires knowledge of the arterial territories in the brain. The three main arteries that supply the cerebrum are the anterior cerebral artery, supplying the medial part of the cortex, the middle cerebral artery, supplying the largest part of the cerebral cortex, mainly the lateral component, and the posterior cerebral artery, which supplies the inferior temporal lobe, occipital lobe, and thalami. This slide looks at the coronal view of the neuroanatomy of the brain in relationship to those arterial territories. This slide reproduces the coronal view of the arterial territories, but then shows you the axial view as well. And most brain imaging is done in axial view. All CT scans and the majority of what we look at on MRI scans are axial view. And you can see the different territories depicted on this slide. This This is a normal magnetic resonance angiography, or MRA, of the brain, looking at a coronal view with both the anterior and posterior circulations. The anterior circulation vessels are labeled in red. You see in the neck area we have the ICAs, internal carotid arteries. They travel up, they make about a right angle turn into the Peters bone, then another right angle up into the cavernous sinus portion where they make that little S or siphon shape. And then at the top divide into the middle cerebral artery and the anterior cerebral artery. The proximal middle cerebral artery is called the M1 segment, and the distal ICA and proximal MCA area is an important area to recognize even clinically based on the history and exam as a possible location for a blockage, because we now know that we can perform thrombectomy, take out those clots with a catheter if there's a clot there. And there are clinical clues that tell us if the lesion is there, if the blockage is there. The posterior circulation, as you can see, consists of the vertebral arteries coming up from below. The first good branch there you can see that's prominent is the posterior inferior cerebellar artery, or pica, goes to the lateral medulla. And the two vertebrals join to form the basilar artery, which is in the front of the brainstem, especially over the pons. And in the midbrain area, the basilar artery divides into two posterior cerebral arteries, or PCAs. The PCAs are shaped the way they are because they wrap around the midbrain and then supply the inferior temporal lobes and go back to the occipital lobe. The middle cerebral artery, or MCA, is the largest artery in the brain and also has an angle that is amenable to emboli entering it. So it's a common location for occlusion to cause ischemic stroke from an embolus, traveling either from a large artery atherosclerotic lesion in the carotid artery, for example, or from the heart, cardioembolism. One of the unique things about the cerebral arterial supply is the circle of Willis, the roundabout at the top of the brain. Because of that roundabout, if you occlude the carotid artery, internal carotid artery, you rarely get involvement of the ACA territory. Your infarction almost always is in only the MCA territory because you have great collateral circulation through the circle of Willis to the ACA, anterior cerebral artery. So when people come in with face, arm, leg weakness, it is rare that that's due to ACA plus MCA. It almost never occurs. It is almost unheard of to have an ACA stroke plus an MCA stroke. What's happening instead is something different. It's about where the blockage is in the MCA. So if you look at this slide here, the neurons, the cortical spinal tracts coming from the medial brain in the ACA territory, from the leg area, they travel through the internal capsule in the MCA territory. They join the cortical spinal tracts coming from the arm area, the cortical bulbar tracts coming from the face area, in the internal capsule. And so actually, when someone has a face, arm, leg weakness, it is more commonly due to a problem in the subcortex, and the blockage then is very proximal in the M1 segment. Okay? A more distal M1 segment might not catch the leg area, might give you just face and arm. So that can happen too. Because of the new era of thrombectomy and the need for EMS especially to recognize a potential thrombectomy eligible patient in the field, the acronym VANG or VANG was developed. And we've mentioned it before, but now we're going to tell you why specifically it has clinical utility. When a patient has both a hemiparesis, and when I say hemiparesis, I mean face, arm, leg weakness, or just face, arm weakness. Doesn't matter which. Or just arm, leg weakness. Some combination, but at least 2 out of the 3 face, arm, leg weakness. What do we mean by hemiparesis? Along with any one of the VANG findings. Visual field deficit, aphasia, neglect, or gaze preference. Any one. then by definition, the patient is so-called VAN positive and might be eligible for thrombectomy because it suggests there's a blockage in the M1 segment, that first part of the middle cerebral artery. That's a very important thing to recognize clinically. Emboli are the most common cause of ischemic strokes, typically coming from large artery atherosclerosis or from the heart. And so they tend to go distally. And so in the PCA, posterior cerebral artery, the most common stroke syndrome is a distal PCA blockage. And when it's distal, it goes all the way to the occipital lobe, and the patient has a simple visual field deficit, and that's it. No other abnormality. However, sometimes the PCA can be occluded more proximally. And when that happens, there's ischemia to the occiput, of course, and potentially the superior temporal lobe, inferior temporal lobe. So you can have a hemianopsia or a quadrantenopsia. But in addition, there's ischemia to the thalamus with contralateral hemisensory loss. There may be ischemia to the midbrain, giving you a hemiparesis. And if it's on the left side, you may have a receptive aphasia as well. So one thing I want to point out is that sometimes proximal PCA occlusions can mimic MCA occlusions. And another thing to point out is that even though the literature is not as strong regarding the value of thrombectomy in these cases, there are times when it is completely appropriate and it is effective to perform thrombectomy in a proximal PCA occlusion. That's not possible in a distal PCA occlusion. You can't get the catheter that far back. But one must recognize the potential for thrombectomy in a patient with a proximal PCA occlusion who presents quickly enough. Thank you for viewing and listening to this presentation. This is a DLG Insight production, innovative neuroscience ideas and thoughts on education.